Good afternoon, everybody. Serous macular detachment in diabetic macular edema. We know that now OCT, as per the OCT, there is focal, diffuse, cystoid, or tractional macular edema, and any of these types associated with macular serous detachment is called SMD or serous macular detachment in DME. So there appears to be a mechanical basis in the development of serous macular detachment in DME because it occurs in eyes with greater central macular thickness in all central subfields. And external limiting membrane discontinuity usually happens when there is increased central subfield macular thickness. And what happens here is when there is a microangiopathy with diabetic macular edema, there is disruption of the inner blood retinal barrier and excess fluid reaches the subretinal space in large amounts. And when this excess fluid is not removed by the retinal pigment epithelium, it results in a neurosensory detachment at the macula. And hypertension actually adds to the insult by causing ischemic damage to the retinal pigment epithelial pump. And again, this macular serous detachment happens. And we know that now the latest OCTs have shown these outer retinal defects in the serous macular detachment. Actually, these are the ones which is acting as a path for the flow of fluid, the intraretinal fluids from the cyst and edematous retina into the subretinal fluid. So this has been the high resolution OCT finding, and there has also been findings that larger these outer retinal defects, larger the serous macular detachment. You see the small defect here with a small detachment. So these are the responsible how the serous macular detachment happens. And also another recent finding is presence of hyperreflective dots in the subretinal fluid in serous macular detachment. This happens when the communications are there, and large communications means more subretinal hyperreflective dots in and around the serous macular detachment. So these subretinal dots are precursors of subfoveal hard exudate clump, which is a known poor prognostic factor. So the larger the size of communication, more the number of subretinal hyperreflective dots. So there, if you find a small number of hyperreflective dots, prompt treatment has to be given, especially in the presence of external limiting membrane defects. So a very good study from Shankar Netralaya has looked into the risk factors in serous macular detachment. The most important factor is systolic and diastolic high blood pressure, which causes this serous macular detachment. So there is increased transudation of fluid and ischemic damage to the RP, causing the serous macular detachment. Other studies have shown that it is the elevated HbA1c, anemia, renal parameters high, and the severity of retinopathy, which causes serous association with serous macular detachment. So why the serous macular detachment in DME is associated with less favorable prognosis compared to the other OCT subtypes is because there is a disruption of photoreceptor integrity in serous macular detachment. This is seen as ELM defect or ISOS defects, that is the photoreceptor damage seen on OCT, and also this hyperreflective foci in the subretinal fluid as well as in the outer retinal layers are associated with poor prognosis in serous macular detachment. As Sir has already mentioned, monthly bevacizumab injections have shown that more reduction happens in diffuse type of edema than serous macular detachment, and it has been shown in several studies that the diffuse type edema has better visual acuity improvement than the serous macular detachment group or even the cystoid macular edema group. So steroids again have shown better prognosis and better results as far as the vision improvement and macular edema reduction compared to bevacizumab in several studies. Laser has been shown to be ineffective in this subtype of macular edema when there is a serous macular detachment. However, the combined therapy, that is anti-VEGF or IVTA followed by a macular photocoagulation has shown to be effective in some of the studies, but however, we don't have fixed protocols. As per large randomized trials, we don't have fixed protocols, and it has to be individualized to the patient. There have been some reports of micropulse yellow laser and aflibercept, which is just into the market, which shows promising results in serous macular detachment. And we are yet to see the results in real world scenario. There are some SMD mimics actually. I will put few case scenarios wherein we really need to look at the diabetic macular edema, a diabetic hypertension patient with defective vision in both eyes since 3 days. Here a lot of hard exudates are there. You have cotton wool spots here and macular edema, but OCT shows bilateral macular serous detachment, especially the left eye looks like a CSCR. So we did fluorescein angiography, which surprisingly neither shows CSCR leak nor microaneurysms leak here, which should cause a macular serous detachment here. Even in the left eye, if you see, there are severe NPDR changes, but not much of a microaneurysm at the macula. You see a lot of late leakage and pooling in the macular area. This patient, now whether it's CSCR, whether it's diabetic macular edema, investigate him. All the systemic parameter here, only catch was this, 220 by 120 accelerated hypertension. Here, so this is the most important thing in serous macular detachment. Control, send the patient for control. Later start the intraocular treatment, whether it be intravitreal injections or laser or whatever. First, the control of hypertension. And another case scenario, you have a severe NPDR and DME patient lost to follow-up since 1 year. Here he comes with defective vision. It looks like a severe NPDR picture. And OCT shows a subretinal fibrin kind of material under the serous macular detachment, and you have a diffuse spongy edema thickening. So now whether it's a CSCR or whether it's a diabetic macular edema, these are some of the the situations where you think whether it's a CSCR or a diabetic macular. So here FFA, as Sir has said, the importance of having a baseline fluorescein angiography. Here you are sure that there is no CSCR underlying the serous macular detachment. You see the microaneurysms and late cystoid macular edema here. So the treatment is, this patient underwent a combined treatment of intravitreal Lucentis with focal laser to the microaneurysm, direct focal laser, not a modified grade. So here the third case scenario is a left eye defective vision in a patient with diabetic and hypertension, 612 vision. Now you see you have a mixed retinopathy picture here with moderate NPDR changes and multiple cotton wool spots here. You see the OCT here, there is a serous macular detachment, even in the left eye, bilateral serous macular detachment in the setting of a mixed retinopathy. But carefully, if you look at it, there were high RP defects in this OCT. So here you see this RP window defects here in the right eye, and in the late stage you see this severe NPDR type of leakage. Here also carefully look at this. This is an area of diffuse RP epitheliopathy which is leaking here. So the patient has a mixed retinopathy with chronic CSCR, which is a mimicker of SMD in diabetic macular edema. Treatment is with low fluence PDT for CSCR. So I am concluding. So the relevance of serous macular detachment. The OCT has recently identified outer retinal defects in the serous macular detachment responsible for the SMD. With growing application of on-fast OCT, we will be better able to see the retinal microangiopathy and determine the pathophysiology more in SMD. And the presence of SMD in DME may be associated with subretinal exudation, which has been reported to be a poor prognostic indicator. And if you see subretinal dots, few subretinal dots, these are precursors of subfoveal hard exudate clump. So prompt treatment in this finding in OCT helps in attaining a better visual prognosis in the presence of external limiting membrane defects on the high resolution OCT. So the treating ophthalmologist should always get a complete systemic workup when you see a serous macular detachment to at least pick up the hypertension, which is the most important factor to achieve a good metabolic control in this disease, in this patient, before you start the treatment for macular edema. Intravitreal steroids have been shown to be more effective than anti-VEGF in this setting of SMD, but the risks and benefits have to be weighed and individualized to the patient. So further studies will help us better understand the pathogenesis, especially the outer retinal discontinuity, and better treatment of SMD. Thank you.